Morning, everyone, and I would request Dr. Sharma to please start the first series of webinars for the first time after USI meeting. We are starting our webinar series, Smart Learning Courses for all the members of USI. And this was the basic idea which was started by Arun Chawla sir. And we used to have it on every Tuesday at 7 p.m. On request of the students and few members, we have changed the timing to 8:30. And this is only with the view that you would finish your OPDs and the students will finish their rounds and will be able to join us in larger numbers. So I request Dr. Sharma to please start the proceedings and invite the president and secretary and thereafter his talk.
Thank you, ma'am. Good evening, President Dr. Lalit Shah sir, Dr. Arun Chawla sir, and Sujata ma'am. It's really a pleasure to be part of ISU, and under the leadership of Sujata ma'am, we are starting this smart learning program, which has been a great initiative, which has gained great heights under the leadership of Dr. Chawla sir. So let me first begin by asking Chawla sir to put his remarks and then followed by Dr. Lalit Shah sir's remarks, and then we can start with the program.
Dr. Sharma, thank you very much. I think President sir is here to give his opening remark. What I'll say is very few words. This program, the script of the program is very good. The topic is very good. The speakers are very good. Those who are practicing endourology, especially the PCNL, tend to gain a lot for this program. And those who have not adopted supine PCNL or those who are improving their proficiency, this will be a great webinar for them to attend. Thank you very much.
Yeah, sir, I fully agree with this because over a period of time, change is the only constant thing in life. And every surgery evolves, and from prone we have come to supine PCNL, and those who are doing supine PCNL have virtually given up doing prone PCNL. May I now invite our President, Dr. Lalit Shah sir, to give his remarks.
Good evening, everyone. I must congratulate ISU and USI for this wonderful focused program. And I'm sure that with this focused program and the expert material and expertise and their experience, each and everyone, including the speakers also, will be learning something. By the end of this program, everybody will be much more wiser than what they were before this program, so as to offer a better treatment for our own patient protocol. And I must congratulate ISU for working out this great opportunity, and I wish best of luck to this program. And I request our secretary, Dr. Uttam Mittal, to share a few words. Thank you.
Hello. Can you hear me?
Yes, sir. Yes, sir.
Dr. Sharma, can I don't think my video is on. There's some issue. Or can I talk from our president's mobile? I think that will be better. Okay. So good evening, everybody. Welcome to this ISU USI Smart Learning Program. I don't know if it is smart or not, but definitely it is a learning program. So as you all know, that PCNL is close to the heart of every urologist who is practicing, especially in India. You have to learn PCNL, otherwise you will not be able to survive anywhere in this world. Now, as you all know, that the PCNL was started in the year 1976. That was the prone PCNL. After about 11 years, the supine PCNL was described and started, but still it has not picked up. There must be some reason, but there are some situations where you have to do the supine PCNL. That is, if the patient is very obese and or there is some spinal deformity or patient has got COPD, where making the patient prone has got some issues. So supine PCNL, as most of the time, it helps the anesthetist as well as it helps the patients. Now that's what they are going to decide, describe and deliver it. And I am sure after these deliberations, everybody will learn, as our president says, that everybody is going to learn. And another thing for me to mention that the faculty today, I know the Sharma is very known in this field of PCNL, but the other two faculty members, Dr. Arvind Panda and
Dr. Chandra.
Dr. Chandra Mohan. I must say that both of them were my student. It's nice to see that they have taken the role of teachers now, and I'm sure at the end of this program, many of you, the students today, are going to be the teachers in future. With these few words, I must congratulate the ISU and USI, and please start the proceedings. Thank you very much.
Thank you, President Sir and Secretary Dr. Mete. Yeah, we can start the program now.
Thank you, ma'am. In fact, our heartfelt thanks to both President and Secretary, because they are in Bangladesh at present, and they have logged in from there. They are attending the Bangladesh National Urology Conference. I think, ma'am, we can start.
Please start. Dr. Chandra Mohan is already there. He has checked the slides.
I have contacted Dr. Arvind, and can I start my screens? Can I share my screen? Yeah.
Yes, we can see your screen.
Yeah. Good evening, everybody. Today's topic is percutaneous renal access in supine PCNL. And when we talk about a percutaneous renal access, it can be either fluoroscopy guided, ultrasound guided, or a combination of both. And at the same time, we have taken supine PCNL as a topic. And of course, there would be comparison between this particular modality of approach compared to the prone PCNL. And today we are lucky to have Dr. Chandra Mohan and Dr. Arvind Panda along with myself, who would be deliberating on these particular aspects. The basic idea would be to give you practical tips and tricks so that anybody who is keen to start supine PCNL would feel confident of doing the same. Now, the first and foremost thing that comes to our mind is what is the position for supine PCNL? And if we look at the evolution of the positions that have come from prone to supine PCNL, there are different types of positions that we come across. And when I went through it, there are something around 15 to 20 different positions that have been described. But this has been a presentation at 2014 EAU, where they described that the first original supine PCNL was described by Valdivia in 1987. And now we are in 2024, where supine PCNL has really picked up. Now, how did this evolution come about? The original Valdivia supine position described in 1987 was where the patient was placed supine with a 3-liter saline bag below the ipsilateral flank. And of course, the landmarks which have been constant through the history of supine PCNL have been the posterior axillary line, the iliac crest, and the marking of the ribs. Now here, the idea was that you raise the legs in such a way so that or raise the flank in such a way so that the kidney gets bit up and a puncture is easier. Now, this particular position was then modified by Galdeco, and he introduced some variations in which the contralateral leg was fixed and flexed and the ipsilateral leg was slightly extended with the leg supports. And again, a 3-liter bag filled with air or saline was utilized, kept below the flank to raise the flank to 20 to 25 degrees. Subsequently, there have been multiple modifications. In 2007, it was more of a supine anterolateral. Then in 2008, Falhatkar described complete supine PCNL. Then came the Bart's flank-free supine position, and then a semi-supine position where the flank was raised to about 45 degrees. In 2012, first time the flank free modified supine position was described, and the idea was to keep the flank free so that more space is available for maneuvering the nephroscope. And at the same time, an oblique supine decubitus position was described, where again the angle was 45 degrees. So in both the scenarios, the flank was kept free, as in contrast to the original positions where a 3-liter bag was put in. The difference between the two positions was one elevated the flank to 15 degree and the other to about 45 degree. I should also like to mention few contributions by our Indian urologists. The one initial publication that I could come across was by Dr. Sanjay Kolte from Nagpur, where he published his observations about supine PCNL in 2013. Subsequently, Dr. Giusti from Italy published his double S position in 2018, where the tilt was 30 to 35 degrees. Now, if you look at it, it initially started with a tilt of about 30 to 35 degrees, came to 15 degrees, and then again people brought it to about 45 degrees. And here the alteration in this double S position was that the assistant had access to the upper urinary tract by standing between the patient's leg. So this was one of the ways in which ECIRS could be done very easily. In 2019, Dr. Aditya Sharma from Lucknow described his flank-free oblique supine modified lithotomy position, where again there is a torque given to the upper part of the torso, which gives a lot of free space in the flank region. In 2020, Giusti again gave a different position, where he said that a simple roller that is used commonly for swimming can be kept beneath the flank so that the tilt is about 15 to 20 degree. And then in 2023, Dr. Sunirmal Chaudhary from Calcutta described the Calcutta position, where he has described keeping two bolsters not vertically but horizontally, one beneath the shoulder and one beneath the buttocks, so that the flank is free and the tilt is about 20 degrees. Now, basically, the idea of all these modifications and variations in these positions has been increase the flank working space, give the leg position in such a way that a combined approach can be done for complex stones. And there have been marked differences in the flank elevation angle from 0 degree as described by Falhatkar to up to 45 degrees, where the basic idea is get easier access to the calyx without causing any damage to the viscera. Now, the basic question that we need to answer is why some flank elevation is needed. Now, the answer is very simple, that the tract becomes horizontal when the flank is elevated. And if there is no elevation, then there will be a tilt downwards. And at the same time, when there is flank elevation, we get more working space. Now, so what are the basic steps in positioning the patient? The first thing is mark the posterior axillary line, give modified lithotomy position, insert bolsters under the scapula and pelvis, confirm on C-arm that the position is correct, and then you can drape the patient. And through a couple of slides, I would explain each of these aspects. Now, when we talk about marking the posterior axillary line, it is imperative that it should be done in as much as possible in an anatomical position. Now, I will show two videos which will exemplify this particular statement. In one, on the left-hand side, the patient is sitting with his back which is not straight, and there is an arc of the back. And in the second one, he is sitting straight. And you can see that there is a difference in the way the two markings of the posterior axillary line has come about. And at the same time, when we look at this particular video where the patient is supine, we are seeing three lines now being drawn. One in supine when he is lying down, one when he had his back curved, and when he had his back which was straight. Now, why this becomes important is where here I did a small experiment where I taped a wire at the level of the posterior axillary line in the anatomical position, and you can see it in the form of a marker which is seen here. Now, if the patient is, we are marking this posterior axillary line in the supine position, this is the point where it will come. While if we are doing it in an anatomical position or in a sitting position, this is the point which is where it will come. We all know that the puncture has to be below the posterior axillary line. And with this figure, it will be very obvious that why marking the posterior axillary line in an anatomical position or in a sitting position is important, so that we do not injure organs. The one organ which we are really worried about injuring is the colon. Now, this is how these three lines have come about. This is the head end on the left hand side, and the first line is when the patient is in supine position. The second is when he has his back which is not straight, and the third when he was sitting with the back straight. And we are going beneath the posterior axillary line so that we do not cause any damage to the viscera. Now, this is the modified lithotomy position that I tend to give, so that there is access from both ends, and at the same time, once I pass the ureteric catheter, I just have to move on the other side and go ahead with my puncture. Now, what are the bolsters that we need to use? Different people have described different bolsters. What I do is I use thermocol bolsters, which are of two sizes. One which has a width of 5 centimeter and the other which has a width of about 7.5 centimeter. For patients whose weight is about up to 70 kg, I think 5 centimeter width bolsters are good enough. But for more heavier patients, I use the bolsters which are 7.5 centimeter thick. Now, this is the position that is achieved. Now, one aspect which I mentioned was confirm on C-arm that the positioning is correct. In the initial learning curve, very often when the tilt is given, the worry is that if we don't give adequate tilt, we might end up injuring the organs. And in this process, the calculus is seen superimposed over the vertebra. So once the position is given, we need to check on the C-arm that the calculus is very clearly seen away from the spine and is not superimposed over the spine. Even sometimes a question is asked that if thermocol bolsters or specific bolsters are not available, what can be done? The answer is simple. For thin patients, one can wrap a towel around a half-liter saline bottle, or for very heavy patients, about around a 1 liter saline bottle, and they can be inserted beneath the scapula and beneath the buttocks. Now, this is a video which describes this entire process. This is the line which has been drawn, and which is marking the posterior axillary line. We are going to do a puncture on the right side. So the lithotomy bar on the right side is kept in such a way that it is at the level, the bar or the place where the leg is strapped is parallel or exactly at the same line as that of the operating table. The patient's ipsilateral leg virtually becomes extended straight. There is enough space between the two legs where a surgeon can stand. The two bolsters are then kept, one beneath the scapula and one beneath the buttocks. And then the patient is brought closer to the edge of the table. However, a small precaution that we need to take care is that when we bring the patient closer to the edge of the table, it should not be beyond the edge of the table. Otherwise, the metallic bar which is present beneath every operating table will interfere with our proper vision on the fluoroscopy image. And once this particular position is achieved, you can arrange the monitors so that if you are making a lower pole puncture, the monitor where the camera is attached is right in front of you. Now, coming to the actual steps of fluoroscopic guided puncture. The first question which most of the residents would like to ask is, which calyx to puncture? Should it be in prone? We know that it is a posterior calyx, but in supine, it can be an anterior or a posterior calyx. It does not matter which calyx we are puncturing, and I will explain that. Now we know the reasons why a posterior calyx should be punctured in prone PCNL, because it gives a direct path to the renal pelvis, and we are not injuring major part of the parenchyma, and we are going through the avascular Brudel's zone. But this is the film where the patient is in prone position, and you know that if we are going from the skin above, where I have marked the posterior calyx, why the posterior calyx is the easier option to do. But what happens in supine PCNL? We are looking at two calyces, the anterior calyx and the posterior calyx. We also know that we are giving a tilt to the patient, which is about 15 to 20 degree, so that the needle goes straight in. And herein you can appreciate that whether you puncture the anterior calyx or you puncture the posterior calyx, it will not make much of a difference. The trick is the surgeon should realize which calyx will give him the maximum clearance of the calculus. Now, these are the images, reconstructed images, where if you see from above downwards, if a tilt is given, the calyces which are coming directly in front of us in the last lower down images, both the calyces, the anterior and the posterior group of calyces, are right in front of us. Of course, we need to remember that the classical anterior and posterior orientation is seen only in the middle group of calyces, while the polar calyces are oriented towards their respective poles. Now, what does this mean? Now, if a patient is tilted, the upper calyx is going to come closer and the lower calyx will be away. So, when you are trying to puncture the lower calyx and you are going too far below the posterior axillary line, the track will be longer. And I will come to this particular aspect in details further. The next question is, which are the calyces which can be punctured during supine PCNL? Now, consider this particular image. And when a tilt is given, these are the calyces in front of us. The medial most upper calyx is one which should never be punctured, and the medial most lower pole calyx is one which is most difficult to puncture because the buttocks come in the way, and barring these two calyces, virtually all the calyces can be very easily punctured in supine PCNL. Now, one fear which every person who wants to start supine PCNL is injury to the colon. Now, I would like to bring to your attention two classical articles, one by Hooper et al. In 1987, which said that the colon is retrorenal only in 2% of cases in supine position as compared to 10% in prone position. Somebody might argue that this was before the pre-CT era, but a latest article in 2021 by Her et al. Mentioned that posterolateral or retrorenal colon are again more frequently seen in the upper and lower pole of the left kidney in prone position as compared to the supine position. So theoretically also the risk of injuring the colon in supine position is much less as compared to prone position, provided you are below the posterior axillary line. Now, what about injury to the viscera, especially the liver and spleen? And we know that they are positioned posterolaterally at the level of the suprahilar region, because above the hilum of the kidney is the area where these organs have their largest dimension. Now, we need to understand few simple things. Now, this is the marker which indicates the posterior axillary line, and this is the upper pole of the kidney. Now, if we are going to go just beneath the posterior axillary line, say a centimeter or a finger's breadth below, then it is very high chance that we may end up injuring the spleen. And the same may occur if it is on the right side. However, if we give a tilt, and this is the posterior axillary line, instead of going just beneath the posterior axillary line, if we go at least about 2 to 3 fingers below the posterior axillary line, if we are puncturing the upper pole, then the chances of injuring viscera like liver and spleen would be negligible. What about relation to the diaphragm and pleura? Now, one aspect which every endourologist who does PCNL would agree to it is that if we are puncturing anything above the 12th rib or the 11th rib, we do traverse the pleura. But if we are going to enter a pleural space and damage the lung, then the risk of developing a pneumothorax or a pleural effusion or a hemothorax is high. And this happens if we are going to go above the 10th rib. So, but there are a number of articles. One article which is there in a special issue of Journal of Endourology by Dr. Pankaj Maheshwari, which says that the risk of injury to the lung is highest if we go above the 10th intercostal space. Now, how do you puncture? Once you have understood these anatomical aspects, we all know that there are two classical ways in which a puncture is attained by fluoroscopy guidance. One is the bullseye technique and second is the triangulation technique. And often people ask, is it possible to do a bullseye technique using supine PCNL? And the answer is yes. The idea is you rotate the siam beneath the table in such a way that the calyx that we intend to puncture and the needle form a bullseye and you can go in ahead. I have tried doing it, but honestly speaking, I have found it more cumbersome. In fact, the triangulation technique works easier, and when people start doing supine PCNL, often the answer is that they find puncture easier in supine as compared to prone PCNL. So in triangulation technique, we all know there are three things which are important: the site of skin puncture, the angle of puncture, and the depth of puncture. Let's see each one of them. The site of skin puncture is determined by marking the calyx to be punctured with the siam at 0 degree by keeping the needle on the body surface. And as I have already mentioned, the puncture should start below the posterior axillary line. But here you can see that I have made 3 stars. If you are going to puncture the lower pole, just go a finger's breadth or just beneath the posterior axillary line. If you are going to puncture the middle pole, go at least 2 finger breadth below the posterior axillary line, while go still further down if you are going to puncture the upper pole. And the reasons for this I have already mentioned in the anatomical description of the supine PCNL position, because this is how you can avoid injuring the colon and as well as the viscera and the avoid puncturing the pleura and the lung. This is a case where I had made 3 punctures right at the beginning because it was a very complex case. And you can see how the length of each puncture varies when you compare it with the posterior axillary line. Let me explain it in a minute further. This is the upper pole puncture. This is the posterior axillary line marker. If we go just beneath it, we are likely to injure the colon. So we need to go much lower. This is middle pole puncture. You go bit lower and you can directly enter the middle pole. Now, this I am trying to explain with the help of CT images in this particular patient, where if I have to puncture the lower pole, I would go just below the posterior axillary line. I would be still lower down for the middle pole. This is still lower down as compared to what we have seen because it is in the line of the infundibulum. And this is for the upper pole, which will be much closer to the midline. So this is a supra 11th puncture which I had done during supine PCNL, and you can see the distance from the posterior axillary line over here. As I had already mentioned, the medial most calyx is the most difficult to puncture and is practically never needed also. Now, what should be the angle of puncture? Once we have ascertained what should be the determining the site of skin puncture, what should be the angle of puncture? And in plain simple words, it should be parallel to the floor. You can make small adjustments later. Let me explain this with the help of 2 videos, which are unedited videos of the puncture that I have achieved. And I am running both the surface view and the fluoroscopic view at the same time. Now, I have kept my needle over the surface with the siam at 0 degree. I am going to puncture the lower pole. I am going just beneath the posterior axillary line. And mind you, I am still very close to the ribs. I am using a 18 gauge needle. As you can see, the angle of entry is parallel to the floor. As I am trying to enter, the needle is just touching the ribs. So I will have to make a slight adjustment so that I can go in. This patient is under regional anesthesia, so the movement of the kidneys are there. And now once I have gone in, my needle goes in straight. You can see the indentation of the calyx and the kidney moving. And this is a very sure sign that you are going to enter in the correct direction. And once you have entered, you get a giveaway sensation. Most often you don't need to aspirate because the fluid comes out very easily, and the guide wire more often than not enters into the ureter straight. So the surest evidence that you have punctured the calyx is two. Initially, the indentation of the calyx that you see on a fluoroscopic monitor, and the free flow of saline that comes out once you remove the hub. The third aspect of puncture is how do you assess the depth of puncture? Now this is simple. All the medial and lateral adjustments of the needle are done with the Siam at 0 degree, while the antero-posterior adjustments are done with the Siam tilted 30 degrees cephalocaudally. Now, if we look at the first picture, which is on your left-hand side, and the needle is seen entering the calyx, but no free flow of saline is coming, it is possible that the needle is either above, that is anterior, or it is below the calyx. So how do we remember this? I often tell a mnemonic for this key, remember BA. If your needle is below, it means it is anterior. If your needle is above, it means it is too posterior. So below is anterior, above is posterior. And if you remember this, you can very easily make the adjustments of your needle and get it in the correct alignment. And then you bring the Siam back to 0 degree and achieve the puncture. I would skip this video, which is explaining exactly the same thing. Now, this is what I exactly wanted to say, that if your needle is above, what is it above means? Above means is more, below is anterior and above is more posterior. So you make the adjustments in such a way that your needle is directed more superficially and you align yourself with the calyx and the infundibulum. Now, another question which is often asked is that the kidney tends to move a lot during puncture in supine PCNL. And this really is a problem which has been addressed by a lot of people, where people found that especially if there is low perirenal fat, and if you are puncturing through the lower pole calyx, which is often done in supine PCNL, the chances of kidneys getting displaced are high. This is important not only during puncture, but also during dilatation of the trach. So certain tips and tricks which have been mentioned are, during puncture, one can apply abdominal compression on the opposite side so that the kidney is stabilized. Once the guide wire is passed in through the ureter and comes in the bladder, we can use the cystoscope, retrieve the guide wire so that we have a through and through access. And if we use smaller caliber renal access sheaths, they appear to somehow cause less renal mobility as compared to large bore renal sheaths. Now, few important practical tips. Often we are not able to cut the thoracolumbar fascia, but mind you, most often than not, the puncture is through the lower pole, and in that scenario, the fascia which is present is not so very thick. And often we are able to dilate it very easily. Now, while we are dilating, one worry is, are we in the correct angle? And for this, I often say a test which is described as a glide wire friction test. And this was first described by Dr. Vasudev Ridhorkar from Nagpur, where you pass a guide wire. Now, you see, if your dilator is in the same angle, the glide wire will move easily. So there is no friction. But if your dilator is in a wrong angle, then the glide wire will not move. So for beginners, this is a very useful trick, that you keep on moving the glide wire as you are advancing the dilator, more by dilatation and less by pushing. And you know centimeter by centimeter that you are going in the right direction. Often people say the surgical field is limited and the movements of the nephroscope are limited. I would not agree to it, because we are more often than not using the flank free position where we get adequate field. And in fact, from the lower pole puncture, it's very easy to enter into the upper pole, where often the fragments go and retrieve them very easily. Of course, one thing is that we should avoid using a nephroscope where either the light cable or the irrigation cable is exactly opposite it, because it might then interfere with the edge of the operating table and we would not be able to have good maneuverability of the nephroscope. So I think with these small few tips and tricks, I have tried to put across my viewpoint about a fluoroscopic guided percutaneous renal access in supine position. And I'm sure once you start doing it, you would enjoy it as much as you have enjoyed doing a prone PCNL. Thank you so much.
Thank you, sir. It was an excellent talk. I think really everybody was spellbound and listening very attentively to you. And you explained it very threadbare, and every point you showed us very clearly. And now I request you to take the talk further. You can request Dr. Chandramohan.
Yeah, ma'am. As at the initial part, I mentioned that one of the ways of accessing it is fluoroscopy guided. But the other way is using sonography or a combination of both. And we have a person who is very passionate about supine PCNL and as well as ultrasound guided puncture. That is Dr. Chandramohan Vaddi from Hyderabad. May I request Dr. Chandramohan now to take over and share his slides?
Yes, sir. Respected seniors, President Lalit Shah sir, Secretary USI Dr. Uttam sir, and ISU program Dr. Sujata madam and Dr. Arun Chawla sir, thank you for giving the opportunity. I am sharing my screen. That is an excellent presentation by Dr. Gyanendra Sharma sir. In fact, he has given the opportunity to me, to be honest. I am fully convinced with the way the Gyanendra Sharma sir explained. There is no doubt even in a single slide, and everything is absolutely scientific. But my aspect is ultrasound guided puncture and supine PCNL. As you all know, ultrasound is not commonly used in India in PCNL. One of the senior surgeon, very senior surgeon in India, said that I am using for last 30 years, none other than Dr. Mahesh Desai sir, whereas I am using for last 3-4 years ultrasound. Why we don't use and how we have to use either in prone and supine PCNL, I will be focusing on supine PCNL ultrasound. There are two conflicts of interest because most of the ultrasound in these videos are done by BK ultrasound, because that is the one which has attachment, and other ultrasounds also have attachments, others have also trajectories, but I am comfortable with BK ultrasound, so those ultrasound videos will be shown. Second conflicts of interest is 50% of the videos are done by Dr. Soundarya and 50% are done, and all the videos are edited by Dr. Soundarya. With this introduction is achieving percutaneous access is the most important step in PCNL. Commonly done under fluoroscopic guidance, as I told, worldwide, not only in India. Cumulative radiation dose for the surgeon and recurrent stone formers, we don't give importance because we don't have objective criteria. What will happen? How many urologists got? How many cardiologists got cancer because of usage of CM? It is very difficult to say. So ultrasound, as you know, why it is important is we always say these techniques of BOP or anterior, posterior tilting and all this is imagination. Why today 270 audience is present? Because as Uttam sir said, this is bread and butter surgery. Second thing is PCNL CM guided is a semi-blind procedure. Whatever applications you use, sometimes urine will not come. In conferences we see, if urine comes, everybody clap. If urine doesn't come 1 time, 2 times, 3 times, sometimes senior more surgeons take 10 times also. This type of is because it is semi-blind and you interpret with 0 degree and 30 degree, exactly needle has to enter. If the system is not dilated, it may not enter. And you are always semi-blind because you are not seeing the structures between the skin and the pelvic calcium system. Only when the kidney moves, you are sure that you are in the kidney. Till that time, where the needle is going, you don't know. You always assume that posterior axillary line, then sitting position posterior axial line, standing position posterior axial line. These are all assumptions. And you think that above 10.3 lung is there, below 10.3 pleura is there, below, as assumption. To reduce that ultrasound, you can reduce. Now, these are the important points. Three-dimensional imaging. No doubt any person who use ultrasound, forget about BK, forget about XYZ, any ultrasound of 10 to 12 lakhs mission also, if you put on the bag, you can easily see the kidney. You can easily see the muscles. You can easily see the rib. These three structures, undoubtedly you can see. You can always see how much depth the kidney is. Let it be obese, let it be thin, let it be child. You can see the depth and the direction. Because ultrasound, whenever you put on the kidney, it will see only the eye front part. When you see with your eyes, normally, whatever the front person you are seeing, that only ultrasound will see. That means if ultrasound is seeing one calyx, means it is the bull's eye of that calyx. If you change the ultrasound position, that calyx will disappear. If you change, one more calyx will come. That is bullseye. Whether it is anterior, whether it is posterior, you leave it. Ultrasound probe from the paraspinal region, if you keep on tilting, whether prone or supine, the convex border of the skin, whichever calyx you see in the center, it is the bullseye. Whichever calyx is disappearing, it is going more posterior. Whichever calyx is appearing, it is more anterior. Whichever calyx is appearing more anterior, it is more anterior. After certain time, you don't see anything, you will see the column. That means kidney is over. That means you can clearly see where you do Siam guided puncture, but you know where is the calyx, which is the bullseye. After the rest of all the surgery, you do Siam. That is the most important use of ultrasound we have to practice. Then this reduces the blindness of the puncture, shortens the tract. See, what is bullseye? You put in Siam, it is the shortest tract. In ultrasound is also same. The advantage in ultrasound when compared to bullseye is, in bullseye Siam, only one dot you can see. But in ultrasound, up to 2 to 3 centimeters, you can see the calyx. You can avoid the rib. You can avoid certain directional problems. So it is bullseye with a wide range so that you can select the needle without viscera. Important. So identification of the posterior calyx is very easy. You put the probe posteriorly, come anteriorly, then do it. I'm not saying you puncture entire calyx with ultrasound. See where you are and then start. Absolutely safe. Then like liver, spleen, so nicely seen, so nicely. More you put jelly, even normal ultrasound of what I mean to say, most of the ultrasounds lowest cadre are 10 to 12 lakhs, medium cadre are 20 to 25 lakhs. These are present in the hospitals. You shift it to the room, you see once, you select the point and shift back to the room, normal room. Then you use the Siam. Avoids intrarenal vascular injury. Why I'm telling is, in supine PCNL, first of all, reaching the renal artery is impossible because you have to go way beyond the spine to reach the renal artery. It is impossible. Very difficult unless you are too rough. Entire needle goes inside and you are doing front and back movements. In fact, in ultrasound guided, either you reach the calyx or you don't reach it. If you combine with Siam, it will become much more scientific, much more scientific. Radiation exposure, of course, does not. See now here, our upper pole is not visualized and stone is in the upper pole. How can you puncture? 90% of the Indians can puncture upper pole in this by imagination. But 10% of the people who cannot puncture will go into the infundibular artery that causes torrential bleeding. Unless it is a large stone where you hit the stone. Even during dilatation, it creates problem. Here, directly you can see the stone in the ultrasound. Now here, if you see 0 degree and 30 degree, absolutely no problem. It is only 1 degree. Wherever the probe is, that is the degree. Whether it is 10 degree, 20 degree, 30 degree. Now coming to the ultrasound guided, fluoro guided. You see the accuracy here. In fluoro guided, you have gone superior part of the calyx. In ultrasound guided, if you keep in the center and don't move, you will exactly go into the center of the calyx. That is, studies are also there. Now, sir has explained so many things, posterior axial line. If you have a retrorenal column, in one of the live conference conducted by SK Pal sir, he has given his case. I have taken this patient to the downwards to ultrasound room because I was under fear in the initial part of my ultrasound puncture. It was retrorenal column because I suspected in the CT. Then I went to ultrasound room, marked where my puncture is safe, and chup chop I have shifted the patient back to the theater. So what the advantage? I tilted the patient more. I have selected the puncture line. From there directly I went into the pelvic elevation system. Everybody clapped. But the real story is ultrasound. Ultrasound said that this is the area where colon is not present. You can see this video. Again, I will play. So much medially I have gone in patient fully tilted. Luckily, patient is a thin patient. See the colon. Everywhere colon is present. If you have gone with the normal mechanism, see, this is the only place where colon is not present. So that area is, you can imagine that area was renal angle area, not even below the 12th rib, renal angle area. So certain things you have to see on CT and ultrasound and get into the picture. If you are very intelligent, you can see in both the things. You can clearly see the red part. You can avoid that and you can go into, so that even small arcuate arteries can be avoided. Sometimes we do in CM not straight, a little comfortable position to puncture the leaks. This can be clearly avoided. How to start? See, whenever you take the ultrasound mission, you have to see the probe type, examination type, patient ID, transducer orientation. After that, you have to select frequency, depth, gain, and focus. One time, if you do this along with radiologist, it is very easy. You write down, it will come easily. It's not a big job. See here, I'm keeping the probe type is curvilinear probe. You have to select probes. 4 probes will be there. One for ultrasound abdomen, one for the Doppler scrotum, one for the echocardiogram, another is transvaginal probe for the pregnancy in routine ultrasound. You select this. After selecting, you go to the kidney, so that superficial and deep in between it will come. Then after that, first you have to practice the probe. In any probe which has an attachment for puncture line, you can put it up or down. So whether you keep it up or down, trajectory will be the same. Only thing is, you have to move the kidney and go to the liver, and then identify which direction you are moving. Anterior you go, colon will come. Posterior you go, kidney will disappear. Superior you go, spleen will come. Inferior you go, the kidney will disappear. So if you do like that, center part of the kidney you keep. Mark yourself your area of interest. Second is, as you know, kidney is more posterior superiorly. So if you tilt the probe more superiorly, exactly in the picture in this will come. That means in that position only, entire kidney can be assessed as if you are in the CT. As if you are in the CT. CT scan is too much information. Same information you will get with ultrasound with good quality. Now coming, you see here, when I am orientation of the probe, whenever I am moving up and down, you can clearly see that. Now here, orientation of the probe again. The liver is coming. Everybody can see liver in the right side. Everybody can see liver in the left side of the screen. That means, depending on the probe, which is superior part of the kidney, which is inferior part of the kidney, it is very easy. Absolutely no problem. Now coming to the longitudinal orientation, you see, if you tilt subhepatic region, entire kidney length is seen. Similarly, you see how the liver and spleen look like, how the kidney looks like. Liver looks a little white, you can say, than the kidney. Same spleen, little white than the kidney. You can easily identify this surface, the margin between the kidney and the liver. If it is like this, it is very anterior. You will never puncture in this position. But just you will see whether hepatomegaly is present or not. These are, you can never miss any viscera. Now see the colon. Everybody should see this. Colon will be seen as irregular white line. Multiple times you move front and back, you can clearly see hastrations and you can clearly avoid the colon. I am telling you, if you use ultrasound probe for only for 5 minutes, practice, get radiologist, put the probe, see the bowel, go below it, see the liver, go below it and mark one area of 4 centimeters. In that 4 centimeter, whatever the puncture through the C-arm you do, fair enough. And now you see adjacent viscera, diaphragm, pleura. You can see on the left, one small line, pleura is coming. You can clearly see white line, pleura is coming. When the respiration comes, it comes down. How much it will come down, how much it will go rib, paramedian, median, lateral, who will calculate on the table after draping? You put the ultrasound probe, wherever, ask the anesthetist to take deep respiration, the white line of the pleura will come down. You mark, don't go above that. Don't go above that. That's all. Now coming to the rib shadow, this is the only problem. Rib shadow looks like a black shadow obscuring entire kidney. You need experience only for this. I must tell you, the crowded ribs is a nuisance in ultrasound. So if the kidney is cost a lot of the kidney, ultrasound needs a lot of skill. This is the one problem where you have to acquaint. The answer for this is, in various positions, quickly move the probe. Whatever direction you move, in one position, a rib shadow will not come into the picture. Now coming to the steps of the procedure, any needle, ultrasound needle is same. Eco-tip needle can come with Cook, but we are using the routine needle. What happens in ultrasound is, skin and 3 muscles will be seen within a nice area of the kidney. No structure should be in between. Your trajectory line should be clearly going through the skin, 1 or 2, 3 muscles, and directly kidney. Anybody can identify this with normal ultrasound also. So once you see, you move in such a that you have to select the calyx. See, identifying the calyx is simple: posterior or anterior, depending on the probe; inferior or superior, depending on which you wanted to go. If it is pelvic stone, whichever is directly in front of your ultrasound probe, you go directly, stone will be seen. If it is calyceal stone and pelvic stone, you have to aim the stone. In such case, ultrasound is very, very useful. One small stone is there in the inferior calyx. You keep the probe to that calyx and puncture. Directly first that stone will come out. After that, pelvic stone will come. Puncture technique, techniques and tips to overcome difficulty. See, you have to hold firmly. If you keep on loosely moving, the skin, subcutaneous fat, the respiratory movements, anesthetist movement, everything will come in the way. So you have to firmly hold when you are puncturing. That means as if you are fixing something, the skin and subcutaneous tissue, so that it will not move, especially in obese patient. Always tilt in the direction of the kidney. Total kidney, if you are seeing, you are safe. Total vertical part of the kidney, if you are seeing, then you clearly know which calyx you are going. For short period of time, apnea. One of the case Gnanendra Sharma sir shown, really spinal anesthesia. All of you who are doing under spinal, really great. I do under general anesthesia. Patient takes so much breathing. Sometimes I feel that why I have to take so much pain. Stop it and then go it. But he has shown nicely. Lot of Indian urologists are doing spinal. But you might be knowing that if you stop the respiration for short seconds, then it is easy. Same applies to ultrasound. Infundibulum calyx alignment is directly seeing it. That's all. If you are seeing only pelvis, you will not puncture. Now coming to the skin stretch and hold by assistant. These are all there for contrast. This is elimination rib shadow tactfully. I already told you have to use tactfully. First of all, when do you need ultrasound? Is it necessary? Why you have to learn? Everybody says, Western people does not know C-arm puncture. That's why they are using ultrasound. Please do not place these comments casually. It is absolutely wrong. Nobody is perfect. You cannot say entire India is perfect in C-arm. Entire Western is not at all perfect in C-arm. That is not correct. Ultrasound is the only way to assess the initial puncture site. This is by rule. Whether you use afterwards C-arm or not, it's up to you. Second point is, the 4 lines here it has given is mandatory you have to learn. For example, impacted PUJ calculus is there. 1 drop of contrast is not going into the kidney. What will you do? Will you abandon the procedure, or will you blindly puncture in 2024 below the 12th rib? Many people can puncture, urine will come. That is not great, but that is not the answer. You have to see with ultrasound. Next, impacted stone in infundibulum. What will you do? Even the blind puncture also you cannot do. Even nobody can help. Then what will you do? C-arm, you put the stone, and lateral to stone you will puncture. Is it correct to imagine like that the depth? Not at all correct. Can you directly hit the infundibular stone of the upper calyx? Not at all correct. Infundibular artery of the upper calyx can lead to torrential bleeding. Multiple and large lower ureteric stones. Again, how can you pass all the lower ureteric stone when already hydronephrosis is there? First to do the PCNL and then tackle the lower ureteric stone is important. Then ureteric stricture. If you are doing any post radiotherapy, you could not get access. What will you do? And recently I got a case where ureter is completely cut off after URSL. What will you do? Will you do ureteric implantation and then the stone? No, only ultrasound guided. So these conditions, better to know the technique than saying that CM is enough. CM is fairly good. Should not do fluoro guided puncture in urinoma, infected hydronephrosis, abscess, azotemia, pregnancy. How can you do it? How can you inflate the system more when it's already fully tensed up? And that is the easiest case for the ultrasound. Then why not you take the ultrasound? And retrorenal column, like I said in the conference, if I have proceeded, I might have gone nicely through the column. Honestly, ectopic pelvic kidney, how will you assess all this 0 degree, 30 degree? First of all, kidney should be in 30 degree to assess all this 0, 30. If the kidney itself is in its own shape, somewhere kilometers away from the liver and somewhere close to spine or crossing that side, crossed ectopic kidney, horseshoe kidney, and pediatric cases, recurrent stone formers. These are the cases. This slide is very important. This slide you cannot throw away. That's why ultrasound is important. Now I will show 5 case scenarios, 5 to 6, absolute indication and how it is tackled. This is one stone. You are injecting contrast, lower calyx is not at all delineating. What will you do? You directly puncture towards the stone direction. 90% urine comes. If urine doesn't come, what will you do? Get the ultrasound, see nicely dilated system. You can see the dip. I will play it again. Water will anybody will show no problem. But you see the dip. You identify the lower calyx. See, nice dilated like C. See the needle how it is coming. See the dipping of the parenchyma. After that, you adjust if you want in CM 1 minute this way or that way. Now you see, you see the contrast after injection. What happens? See, now urine has come. Let the urine come out. It's a system. Now see, nicely it has gone through the periphery and then past the guide wire and then rest of the procedure. This happens many times. In RGP, this happens. In fact, we use flexible ureteroscope to inject the contrast sometimes if the ultrasound is not there. Now, this is again impacted PUJ calculus with lower calyceal stone. Retrograde catheter not possible. Contrast cannot be injected. Now, what will you do? You see so much dilatation. You see nicely the stone is seen and you put it. This is the trajectory. If you properly put trajectory, you don't see anything. Just close your eyes and pass the needle. 90% of the times it will go into the kidney. 90% of the times. But you should orient 2-3 times. This is the attachment. If you have this attachment, it is better. Now you inject contrast and proceed. See how nicely it has gone into the lower lateral peripheral calyx. You cannot have that much center of the stone, provided if you are able to see the calyx and puncture. If non-dilated system, it is difficult. Now here see, this is usually dilated system. Anybody can puncture. Even if you close your eyes without CM, without anything, you will do, but you at least see the column in supine PCNL. Go BC, how I am going behind it. But there is a small trick. There was some superior calyx approach. If you go, you can nicely go to the calyx. So for that superior calyx approach, see ultrasound proof when you are moving up and down, all the calyces and dilated calyces are seen nicely. Whichever calyx you want to puncture, you puncture. This is easy case, but impacted stone. Even you might have done blind puncture in this case. I say this is the case. See, upper calyx stone is there, and you contrast is not going. Radiolucent stone. I have already shown this, but video I have not shown. See, so much dilatation in the upper calyx, so much viscera free space. Now I will go the trajectory. I will move to the upper calyx. See, trajectory I am moving to the upper calyx. See, in any structure in between, nothing. No liver, no intestine. You directly go and puncture it. For safety purpose, I have taken already lower calyx under CM. Now upper calyx I am taking, because if you see, inject nicely, upper calyx is seen, total upper calyx is seen. Then you dilatation and do that calyx. Because if by chance upper calyx cannot be approached, better to park the guide wire in the beginning only. This is a very interesting case. Upper ureteric stone, somebody has attempted, it caused a urinoma, and it is a diverticular stone. All urinoma got infected. Multiple stones in the diverticulum are there. You see here, first you have to drain. You see, so many stones are seen in the diverticulum. Direct you go into the diverticulum. Why unnecessarily imagine? See the needle in the center of the diverticulum. urine definitely will come. You take for culture, you dilate and take it. After that, you can remove the urinoma also. There is absolutely no problem. The entire thing is delineated. Now see, the urinoma is also drained. So urinoma drainage is also very easy. It looks very big. You can directly go into it and put a separate catheter into that. Now, this is multiple lower ureteric stones. I already mentioned, if you cannot pass any ureteric catheter or any, you cannot turn that to radiolucent stone in the kidney. See, this is the kidney. Now you carefully see, this is the puncture. It has gone through the infundibulum. You need little experience to assess the infundibulum. This is this. And then after that, you see how lateral in supine PCNL, sir said that inferior and lower calyces cannot be punctured. It can be punctured through lateral part of the calyx through the ultrasound. See, here also nice undilated tip. Undilated tip calyx, it has gone. There will be failures. I am not saying, I will show only the successes. I will not show any failures. Now, this is the lower ureteric injury with urinoma. This is a disaster. One ureteric stone small was there. Somebody attempted and it has urinoma formed and hydronephrosis is there, fever is there. You have to do something. You have to drain urinoma, see the ureter. Nothing can be passed in the ureter. It is abruptly cut off. It is abruptly cut off. That means while doing URSL, somebody has perforated and not avulsed, perforated completely through and through. No guide wire goes, no contrast goes. Now see the ultrasound. This is the urinoma, large urinoma. This is the kidney. Now we are puncturing the kidney. Nicely window is there. You can see the spleen. And this is punctured and you went inside. You put only PCN. Don't do anything. Now urinoma is drained. This is only PCN, not PCNL. It's a ureteric stone, small ureteric stone. This is the urinoma. Now you put into the urinoma. You take out the needle. And same like urine, it will come. See, same urine is coming. After that, what you do? You do dilatation. And then after the dilator, this is a dilator in the urinoma just below the kidney. And you put one monocat catheter. This is the urinoma drainage. And post-op, you cannot imagine, complete dry. This is the post-op picture. Completely dry. No single drop of urine. And nicely kidney is saved. Avulsion of the ureter, urinoma, or ureteric injury in gynecological ultrasound is very, very useful. Otherwise, you will unnecessarily cause more problem. This is lower ureteric injury, solitary kidney. So I only has done this case, lower ureteric injury in solitary kidney. So what you have to do, you have to be very careful, give Lasix, IV fluids. Instead of giving contrast, you take, see way below posterior axial line, I am there. Posterior axial line is an imaginary line where ultrasound is reality. In line, you will see it. After that, you inject contrast and you be comfortable. Creatinine was 8 in this patient. You cannot afford to do any mistake. If you do 5-6 times blind puncture, perinephric hematoma forms, patient will have severe morbidity in solitary kidneys. And this is again retrorenal canal, which I mentioned, where you have to have guide. Paraspinal region you can puncture. Lot of us do paraspinal puncture. It's only suspicion. If the CT is not done, gone case. If only IVP is done, very difficult. And see, the upper pole system is so close to skin, just matter of 2 centimeters. I know that in this case conference, I am entering into the system. Surprisingly, his contrast was so much filled. I was clearly knowing that I will get the urine in this because I was straight onto it and ultrasound I marked. And while coming out, I ensured that the colon is not injured. And this is the last case where the gas shadow is there in the inferior calyx, so-called emphysematous pyelonephritis grade 1. In these cases, putting ureteric catheter and dilating is not essential. You could clearly see the spleen and identify the marking in the ultrasound. Then middle calyx was approachable in this. Frank pus has come in this case. These are the cases, if you inject contrast and try multiple times in C-arm, you will get fever and you will get perinephric abscess also. See, frank pus, when you aspirate, frank pus. So just put the PCR and come out. No question of meddling and doing the stone. And patient recovered, now due for, in fact, it's due. So this is also a case where PUJ obstruction, parapelvic cyst, and the PUJ, you have to puncture the stone. You think that this is very easy case, but parapelvic cyst is there. Huge pelvic cyst is there. And when you inject contrast, you know how it looks like. It is only like only pelvis. you are seeing only pelvis. You will puncture invariably pelvis. Now, when you see ultrasound, you will see the calyx. And you will be surprised to see the nephrostogram after the calyx is delineated and punctured. See, this is the stone in the calyx. This is the stone in the calyx. You take time, little dip and see. And once you get this, you inject contrast and see, you will be surprised. See how nicely the calyx is protruding from. You can never distend this calyx with RGP. You can never. When you go, see, when you have gone with flexible scope, it has come from the center of the calyx. Center, not even a drop of blood will come. So what does literature say? Same thing, duration, access, radiation will be less, lesser blood transfusion rate, trial and error method, access, the ideal puncture approach, the ultrasound trial and error is better, and increase the accuracy of the puncture. It is better with ultrasound. Even 20 cases is required for ultrasound guided, 60 cases is required for fluoro guided. Somebody has done this thing. Fluoro guided is always when you are teaching, some people will pick up very fast. Some people will be always rotating the needle. It will not puncture the system. Somehow they will miss the calycial system. But in ultrasound, if you get a good ultrasound, that is the only problem. I will tell the hiccups. Advantages, all this already I told. And the issues of concern is hypermobility of the kidney, limited space and slippage of the probe, technical difficulties, visualization of the needle, assessment of overall stone burden, and choice of ideal calyx are difficult. They are very important points. Whatever the topic I have been given, I will not tell negatives about it. Only one slide I will tell. So many difficulties are there, but with experience we are overcoming. The biggest problem I am telling is trajectory plus the attachment. If it is not there, doing ultrasound guided puncture is problem. For that, you have to spend 40-45 lakhs of money, which is useful for the prostate biopsy, which is useful for other things. So to conclude, ultrasound guided PNL is gaining popularity. Gaining means it's already there. In India, it is gaining popularity. Definitive advantage in reducing radiation exposure. That okay. Safe, feasible, and efficient access can be. Familiarity with intraoperative renal imaging you should get. Alignment of needle in desired trajectory can be done. If you sit with radiologist, my wife is radiologist, so I can sit any number of hours in her room and assess again and again every patient. And then I also learned like that. On the same concept based on the next month 10th, with your permission, I am announcing already multiple times this flyer you might have seen. We are focusing on only ultrasound. That day you can see how many failures can. That's why I'm keeping a little dilated systems. Let's hope we will succeed. So as you start to walk on the way appears. So if you don't walk towards the way, you will never find the path. So try to learn ultrasound. If not for PCNL, if you go to the ultrasound room, daily 2 cases if you see with the probe, you will be surprised. You can identify the structures well, and you can definitely, if I can do that, you can easily do that. My success rate is around 80%. But definitely I will use CIAM. I am not saying CIAM is mandatory, but I will use at least where to puncture, not the posterior axial line, not the rib. Where to puncture, every case we are using ultrasound. So I feel that it is useful and complication rates are less. Thank you very much once again for giving the opportunity.
And thank you, Dr. Chandramohan. It was really nice and I suppose it will encourage people to use ultrasound more and more. So we come to the last talk, I think, and it's by Arvind, and I request Dr. Sharma to please invite him.
Yeah, I think Dr. Chandramohan has given a very broad overview about how ultrasound can be used in different situations. And what it emphasizes is that you need to have all modalities in your hand, because you really don't know what situation you are going to face. So if you are familiar with both ultrasound as well as fluoroscopy, it's a big bonus. Of course, most of the people still are more comfortable with fluoroscopy, and ultrasound is not so easily accessible to a lot of people. But the main thrust of our today's topic has been supine PCNL, but prone PCNL has been so far the gold standard. So how does we compare supine and prone PCNL? And for this, we have a brilliant urologist, Dr. Arvind Panda, who is known for his fabulous analysis of various aspects in urology. And I would invite him to give his views as well as what literature says as regards comparison of supine versus prone PCNL. Over to you, Arvind.
Thank you so much. I hope you can hear me. I am really grateful for Dr. Gyanendra to give me this opportunity. this will be a very hard act to follow, because the talk by Dr. Gyanendra was without doubt one of the best I have heard in recent years. Very original thought, and it made it so easy. It made supine PCNL look so easy. And I will just be speaking, and after Dr. Chandra Mohan and Dr. Gyanendra's presentations, this is a very hard act to follow. So I'll just be comparing supine and prone PCNL. What does the literature says? What the evidence says? So the aim of PCNL is always the perfect puncture. Precise access, predetermined calyx, and should be easy to do. And what we should aim for is complete stone clearance with minimal risk. When we talk of minimal risk, we want minimal injury to the kidney, minimal injury to the surrounding organs, and minimal hemorrhage. Should we also aim for the shortest distance, because it might be easier to really maneuver your scope and maneuver your sheath if you have a shorter distance? That again, we need to see. It depends on personal preference. So when we compare, I'll just go to the topic right away. When you compare prone and supine, prone is an all-purpose position. It's quite versatile, and we have been using it for such a long time. So both complex and simple stones can be done with it. And multiple punctures are quite easy, because the amount of space available with prone PCNL is quite significant. So you can do multiple punctures at the same time, or even after sequentially, after you clear one puncture with stones, and you can do the second puncture if you wish. But the problem with prone PCNL has been that you need to change the position. And we all know that when we change the position after doing an RGP, that sometimes is a lot of stress on us, and the heart beats very fast. Cervical spine, the stress on cervical spine, both on the patient and then the stress on your heart during that time, is quite significant. And once we do change, no matter what we do, no matter what we talk, the access to the endotracheal tube is extremely limited. If there is a loss of airway, there is very little we can do when the patient is in prone position, particularly with ampulla inside. And usually we need a flexometric tube if possible. The supine offers several advantages. One is no need to change position. The surgeon can sit. Also, the whole PCNL is under a lower pressure, because it is prone, and when the water flows into the system, it also flows out the same way. So it's a low pressure system. And of course, there's better visibility sometimes, because the stones and the water tends to flow out, visibility may be better. Are there any cons? The jury is out for that. I'll leave that for you to decide. Of course, there are cons, but let's see what the evidence says. So again, as I said, when we aim for a puncture with a supine or prone, we aim for minimal injury. And already Dr. Sharma has explained beautifully that we have to stay lateral in all cases, whether prone or supine, with the posterior axillary lines. So the parameters that we should compare when we compare prone and supine should be the stone-free rates, both immediate stone-free rate and the delayed 90-day stone-free rate, the complications, the time taken for surgery, blood loss, and possibly radiation dose. So our first thing, we should start with access, because this is where the biggest bugbear is. There are many positions, some which gives a larger area to play with, some which gives a lower area, less area to play with in supine. While prone is relatively standard, this is the amount of position of area that you get where you can plan your puncture. So there was a study by Azar et al., where they measured the visceral organ to percutaneous tract distance. And what they found is the prone position offers a significant shorter tract compared to the supine position, is quite significant. Also a significant shorter skin to stone distance. And also much wider angle compared with supine. So that is, when you're talking of tract, you're talking of a shorter tract, you're talking of more angle to puncture, definitely prone seems to have an advantage over supine. The second point is there was a meta-analysis published. Remember, these initial papers are old papers, 2011 and 2012. So I found only one RCT, which is in 2022. So we'll go through all of that. So supine versus prone in percutaneous thoracotomy, they did a meta-analysis. They included 4 studies. 2 were RCTs, and 1 was a prospective non-randomized study, and 1 was a retrospective non-randomized study. The outcomes were stone-free rates and the complications. There were 389 cases and 24 cases, but what they included was actually these 4. The stone-free clearance rate was comparable between these two positions. There was no significant difference in the stone-free rate. There was no significant difference in the bleeding in both positions. The rate of colonic perforation in supine patient was 0.5, and pleural injury. This I was really surprised that they did not find pleural injury in both positions, because when you are doing a prone position, pleural injury is actually, I feel, it's not a complication, it's something, the risk that you accept. And pelvic perforation and failed access, even in both these cases, were comparable. And what about complex kidney stones? So people say, okay, there are easy kidney stones, you can always do a supine. What about complex stones? This is a paper from Brazil, and this was published in 2016, I think 2018. And they compared complex stones, which were Guy stone score 3 or 4, and divided, and then the success, they said, less than 4 mm fragments. So 240 cases had Guy score 3 and 4. 20%, 21% were prone, and almost 80% were supine, 79% were supine. Both groups were comparable, and the success rate, complications, blood transfusion, and the surgical lines are similar for both groups, but there were more visceral injuries and more sepsis in prone cases. So this is about complex stones. Equally good clearance you will get with the supine compared to prone. And if you go to the next one, so this was a randomized control trial. This was a randomized control trial, and supine versus prone. It was published in 2012 in the Arab Journal of Urology. But again, this particular RCT was probably underpowered. It has only 47. It has only 77 patients were there, and 39 and 38 patients. But even if we ignore that, what they found is the operative time was significantly longer in the standard prone position than compared to the supine position. But there was no significant difference in fluoroscopy time and the outcome. Again, what about the real world data? Real world data is this is prospective data, or a report of the CRIOS nephrolithotomy global study, where they compare the data from 5,800 patients over a year on 96 global centers. But remember, this is 2011. This was when it was published. Probably at that point of time, supine PCNL was probably in its infancy. So the vast majority, 4,600, were actually prone PCNLs. What they did find was the mean operative time was significantly low for prone compared to supine. This is actually in complete distinction to all other data that has been published. This is the largest study, and they found that prone is actually a lower operative time. The stone-free rate was higher, and again, however, if you really see, there was a higher rate of blood transfusion and fever in the prone position, and again, prone position also had a lower rates of failed procedures. So I went into the little more detail. So this is what it is. The outcome measure, overall stone-free rate, supine 70%, prone 77%. Again, operative time 90 minutes to 82 minutes. But here I feel that this is because this was the initial part of our experience with supine PCNL. And in 2011, supine PCNL was just gaining traction. I don't think we had all those positions. I don't think we had all those expertise. So this is the early part of the curve. So let's see what we get when we got more experience in it. So this is a recent paper, 2022, published in the Journal of Urology, again RCT, supine versus prone, and this is a multi-center RCT. What they tried to compare was outcome supine and prone, and the supine PCNL was performed in the Bart's-Frankfeld position, modified position, and they saw SFR, stone-free rate, in POD1 and again in POD90. That was the final SFR. What they found in 112 patients, they included the success rate was similar between them both, and even the final stone-free rates at 90th day was similar to both. But supine PCNL, again, this is after the learning curve, has a much shorter operative time, 117 minutes versus 147 minutes. Very significant difference between supine and prone in terms of operative time. This is also the case if you look at the other papers which I just discussed. Supine PCNL definitely is much faster to do because you don't have to change position. And also, prone PCNL had a higher rate of Cleveland 3 complications compared to the supine one. And finally, what about radiation exposure, prone versus modified supine? Now, this is a very interesting study which they did. They use a portable C-arm and they put dosimeter for lens, extremity, and the torso. What they found is the effective dose is 1.3 to 1.5 times higher for lens and extremity in prone position compared to supine. But however, both these positions were still below the recommended limits of the professional exposure. So we need not worry so much about radiation. Having said that, supine has a little lesser radiation dose than prone PCNL. And what about unusual situation? We have been talking about the usual, usual normal curve. What about the long tail? What about unusual situation? So horseshoe kidney. So there is this multicentric study, a retrospective analysis of 10 years in horseshoe kidney in 106 procedures, out of which 67 patients were in the prone position and 39 in supine. Again, as the years passed along, more and more patients began to be treated in the supine position. Initial part from 2008 to 2014, the vast majority had prone PCNLs. So again, there was a bias here. When the BMI was high, the prone position was really preferred. And in prone versus supine, prone had a higher transfusion rate. The complication rates were how comparable, and the stone-free rates were also comparable. But surgical time was again significantly longer in the prone group, which we know what we find. What I have not found data for is what if there's a need for elective ureteral access? What if you have a upper ureteric stone which you need to do a PCNL for? Is supine PCNL better for that? Intuitively, it feels that prone may be a better position to do when you want to access the upper ureteral stone. However, I could not find any study or any data about it. I think that remains open to debate. So I would like to conclude that prone versus supine, it remains a very emotive subject. It depends on what you are comfortable with. However, the data shows that both positions are comparable in most situations. The time of surgery is definitely shorter in the supine procedure. And what we can say is we aim for maximum stone clearance and least complications in the position that they are most comfortable. Thank you so much.
Thank you, Arvind. And now I leave it to all three of you to please take the questions as they come. We have disabled the chat box, but anybody could ask the questions directly as need be. The participants may ask the questions directly, please.
Yeah. Arvind, it has been a very comprehensive analysis of what literature says, and what you have brought out beautifully is that in the initial part, the results were a bit tilted in favor of prone PCNL, but as the experience of people and urologists across the world has increased, the results are comparable and the operating time is short, the radiation exposure is short, the comfort is more. And let me share with you that when I started doing supine PCNL, initially my anesthetist would ask me if whether you want to do prone or supine, but after the first 3-4 cases, she stopped asking me. It used to be only supine because it becomes very easy for the anesthetist. One aspect that you have raised is regarding approach to the upper ureteric stone, and whether we are approaching an upper ureteric stone via a prone or a supine. The approach is dominantly via the upper pole calyx or the middle pole calyx, and I would say that at times it is much easier to approach the upper ureteric stone via prone PCNL as compared to supine, because in supine you tend to look up towards the ureter because of the tilt of the kidney that tends to occur. So, but the advantage is that if you are planning to do a URS for an upper ureteric stone with a worry that it may enter and it might, if it's a big stone, you need a puncture also, then a combined approach with supine PCNL is possible in the same position. And I can distinctly remember doing at least about 8 to 10 cases where I had kept the same position, approached via ureterorhinoscopy, and if need arose, I did a puncture and cleared the remaining fragments. One aspect that we have not touched upon and which is very oftenly asked is that is the track longer and do you need a longer sheath? And in fact, I felt that barring couple of occasions in the last 3 years, I hardly ever needed a 20 centimeter sheath. Most often a 16 centimeter sheath was good enough. So I think another question was regarding anesthesia. I think I agree with Dr. Chandramohan that in the initial part, it is much better that you go ahead with general anesthesia because the movements of the kidney sometimes can be very annoying. But as your experience grows, and more importantly, the coordination that you develop with the anesthetist and the rapport that the anesthesiologist and you develop with the patient, in fact, you can ask the patient because he is awake that you can ask him to hold the breath and make a puncture very easily. So this is something which I feel that in the initial part, go for general anesthesia. As experience increases, you can go for regional anesthesia. Ma'am, are there any further questions?
Sir, there are some questions. If you permit,
Please.
I will answer the ultrasound related part.
Sure, sir.
One question everybody asks is how to get the needle guide. If the needle guide is there, now what to do? One more thing, Doctor, we are fortunate that Dr. Valdivia sir, at the age of 82 years, is attending the presentation now, and he has he has encouraged us, saying that all the presenters presented well. He invented the supine PCNL. He is live with us. And second thing is, in ultrasound, the needle guide will come with each probe. I have shared the number in the people who are attending. I will share whoever wants. They will prepare the needle guide for each ultrasound probe. The only ultrasound should have a guideline. Then the probe, attached probe, the company will not give. Separate persons will make it. The second point is, if the needle guide is not there, what will you do? Put the ultrasound in a position, take the lower probe and center part, lower part of the probe, center part, and then go. That will give the direction and the entire needle will be seen. Not in the middle anteriorly, not in the middle posterior part of the probe, not superiorly. Exactly you direct, fix it firmly, and start from the lower part going towards the target. Imagine you are going to the center of the probe in the deep. So another question is, are you doing ultrasound puncture only in supine or also in prone position? Because I am doing last 3 years only supine PCNL predominantly, I mean 99%, I am using ultrasound in all cases of supine. My experience in prone is less because after the supine I started ultrasound. So naturally more that is there. I think Sharma sir has one question by Sunirmal. Yeah. Dr. Sunirmal Chaudhary is very famous in supine PCNL. He asked to Sharma sir, very difficult question. Sir, please.
Yeah, sir, there are two questions that I have. One is, what is the tilt to the torso that needs to be given? Because literature says that from 0 to 45 degree. I believe that about 15 to 20 degree is good enough. That gives you enough position, maneuverability, and you can puncture. Unless you want to puncture the upper pole and you feel the space is less, you can give it a bit more tilt in the upper part. As regards the question by Dr. Sunirmal Chaudhary, who has devised the Kolkata position, I personally feel that when you have given a tilt, it's the lower medial calyx is one of the most difficult calyx to puncture. There are situations where you have a calculus which is present over there. And what I have done in these situations is I have gone from either the lower lateral calyx or even the middle calyx. And then when you look up, and mark my words, when you look up, you are able to reach most of the calyces of the lower pole via the middle pole or the lateral calyx of the lower. But I'm not comfortable puncturing the lower medial calyx. Lower medial calyx, because very often technically it is difficult. The buttocks come in the way, and then you end up making a puncture which might be probably injuring the infundibulum, and the risk of bleeding increases. Yes, sir, please.
Sir, I wanted to ask for the audience sake, is there any condition where prone is best, prone only can do, supine cannot do? Is there any stone where prone only can do, supine cannot do?
Well, if it's a calycial diverticulum, which is easier to approach via prone position, it would be. But what I have found is that anomalous kidneys, somehow I still feel prone, probably because we are more used to that, is a much better approach. And if you have a large upper ureteric calculus which you want to approach, this will be a best way to approach via prone position.
Sir, I have seen one condition where you cannot use prone with your permission. Superior medial diverticular stone close to the hilum. You have to travel across the pelvis and infundibulum, the opposite in supine. You cannot do, because it will be a vertical paraspinal bullseye in prone, which is very difficult in supine because you have to come horizontally. Whereas in prone position, you will come directly from the back, and most of the times the stone will be safer in relation to the artery, because you are going anteroposterior vertically down. That is the one condition I feel very, very dangerous in supine PCNL.
Well, for
superior medial calyx close to the renal artery.
What sir is saying is very right, but I will also like to say that I have seen that in one of the workshops at Pune, he did virtually this particular stone via supine PCNL only. So experts, he is an expert, he has vast experience in it. But what he is saying is right. But at the same time, when you make a more medial puncture in prone, the risk of injuring the pleura as well as the posterior segmental artery increases. So in some situations, you need to have a more flexible view and keep all the options open.
I think the point to be taken here is all the options have to be kept open. I think that is the point. That when you go for a stone, you keep all your options open. You choose which is the best. If you are comfortable in supine, you do supine. You feel that if prone will be a better option, you can go for prone.
Dr. Sudhir Kumar is having a question.
Sir,
has a question.
Very good evening, sir. Excellent talk by all the presenters. My question is to Dr. Gyananda Sharma, sir. I mean, I am of course, prone PCNL surgeon only. Once in a while, occasionally in some morbid obese patient, I try to do supine sometimes. Based on the experience in prone PCNL, sometimes, whenever you get to operate a complex renal stones, like with stones in multiple calyces or a big stone bulk, many a times, even when you're doing prone PCNL, you tend to, since you have a degree of lot of freedom movements to go into the other calyces when you're doing prone PCNL. So you tend to go into other calyces and try to take out all the stones, whichever calyx is accessible to you. Given a case, suppose since you are doing supine PCNL so frequently, if you have a complex stone involving multiple calyces and everything, would you still try to go for supine PCNL, or you would consider doing a prone PCNL thinking that the chances of you getting punctures would be lesser tracks or anything like that? Any experience or any opinion on that?
Good question, Sudhir. I used to think about it, and I have realized that you can approach a complex stone even by a supine PCNL. See, you can take multiple punctures. In one of the slides that I have shown, that I had already parked 3 guide wires when I had started my punctures, and I went through the lower pole and I needed only one more puncture, because very often from the lower pole, it's very easy to enter into the upper pole in supine PCNL. In prone PCNL, if you do a supracostal puncture, then you can probably clear the lower pole and approach the lower pole much easier. So above downwards is easier with prone, from below upwards is easier with supine. But I think it's just a matter of doing things. Very often we need multiple punctures in prone. In a complex stone, we would also need multiple punctures in supine PCNL also.
But considering the skin to calyx distance in supine PCNL, do you think that the length?
I told you, Sudhir, we have this belief, but in the so many hundreds of cases that I have done, occasionally I don't remember more than 2 or 3 occasions when I needed a 20 centimeter long sheath. Very often the smaller length sheaths are good enough to approach. And that's because if it is from the middle pole, then I go still lower down. If it is upper, I still go lower down. So I think the track is not that long. One more question that I'm having is, what kind of adjustments do I do in obese versus thin patients, and in male versus female? Male versus female, there is no adjustment, but in more obese patients, the bolster that I use is a bit thicker. It's about 7.5 to 8 centimeter thick, as compared to in thin patients, where I use something which is about 5 centimeter. Or those who are not having bolsters, the simpler, because I have done in few workshops where I didn't carry my bolsters. For thin patients, I use a half-liter bottle saline, and for obese, a 1-liter bottle saline wrapped by a drape, and that serves good enough. That's good enough for me.
So
Sir, one
I
question
think
one question is the ECRS we have not addressed. To be honest, the biggest advantage of all this exercise supine is ECRS. As Sudhir told, multiple calciums small are there. ECRS is real boon. You can avoid multiple punctures because now even 1.5 centimeter stone with a high energy and low frequency, you can make pieces and bring to pelvis and give to supine PCNL surgeon. This advantage is not there in prone. This is the absolute advantage for supine PCNL. That is the reason why, in fact, I learned supine PCNL as I was doing more RIRS cases. So going to one calyx to other calyx, I also feel that, like Ananda Sharma sir said, you can easily go from the lower pole to the upper ureter, lower pole to the upper calyx, lower pole to the middle calyx. That is what normally we do puncture. But only upper pole puncture, if you do, is slightly difficult.
I think
so.
there are no further
Yeah.
questions here.
So I would like to really thank all three of you, Dr. Sharma, Dr. Chandramohan, and Arvind. And it was definitely all your program. This entire program was designed by Dr. Sharma, and he decided the topics. And I feel it is necessary that more and more members would come ahead with their proposals for more webinars as useful to you. And I'm sure with the success of this program on supine PCNL, we know how much people like your talks, and we look forward to more from you. So thank you everyone, and thank you for joining in such large numbers. Please do send your recommendations for topics if you have any on a personal WhatsApp or on the ISU email ID. And I thank all the participants and the presenters. Thanks to the president and the secretary USI. And I think we'll call it a day. And good night and thanks again.
Thank you, ma'am. Thank you.
Nice.
Thank you,
Thanks.
Dr.
Thank you so
Chandramohan.
much.
Thank you, Dr. Arvind.
Thank you so much.
Bye bye.